Okay, we are live. Thanks everybody for joining for the third session in our traumatic brain injury seminar series as part of the medical student neurosurgery seminar series. So this is going to be the journal club session, and we're excited to host Dr. Alex Valadka, the chief of neurosurgery at the Parkland Hospital and a professor at the University of Texas Southwestern Medical School. He's a real leader and expert in the field of neurotrauma and neurocritical care, and he's going to be helping to facilitate the student-led discussion here on three of the really seminal or key literature pieces within the management of traumatic brain injury from a neurosurgical standpoint. So just a couple of quick housekeeping announcement kind of things. So in thinking about next week, to round out the series, we're excited to host Dr. Uzma Samadani from the Minneapolis Clinic of Neurology. And she's going to be giving a grand rounds talk that's actually really exciting and timely about the potential future use of robotics in neurotrauma. We also have this coming Thursday, the Neurosurgery Journey series, which will be discussing the difference between MD, MD PhD, and PhD tracks into the neurosciences. So with that, we'll go ahead and get started with the core content, and I'll turn it over to Dr. Valadka to kind of help put some of these papers into context with what was happening at the time in practice, because a lot of these papers came out, I think it was really within like 2 years of each other.
Well, great. Well, thanks. I think it might actually work better if we started going over the papers after each one, instead of jumping right into the kind of picking it apart, like I usually do, or respond to whoever's doing it. We could talk about it then. So, Che, do you have the first paper, I believe?
Yes, I believe so. The paper on a trial of intracranial-pressure monitoring in traumatic brain injury by Dr. Chesnut et al.
Perfect. Why don't you summarize that for us?
Okay. Am I able to share my slides here?
Yep. So it's going to be the that center share screen button next to your camera.
Okay. Actually, I'm sorry. What to do? Okay. Are you able to see one slide?
Yeah, we're seeing the presenter mode. Okay. So I think there's probably like a swap display button.
Yeah. There you
go. There we go.
Okay. So the paper I had was a trial of intracranial pressure monitoring and traumatic brain injury by Dr. Chesnut et al. My name is Shay Ross. I'm a MS2 at University of Washington School of Medicine. So traumatic brain injury is basically an insult to brain tissue due to an external mechanical force. It can lead to permanent or temporary impairment of cognitive, physical, and psychosocial functions with diminished or altered state of consciousness. And it can be due to different types of external mechanical force, including motor vehicle collisions, falls, sporting accidents, such as concussions or injuries from football. And normally, the Glasgow-Coma scale score is used to define severity of TBI and help predict the outcome. And it's a score ranked from 3 to 15, with the lower score representing worse prognosis. And it includes eye, vocal, and motor function, as well as state of consciousness. So for the paper itself, basically they had two things in mind when they went about conducting the trial for this paper. The first was that ICP monitoring is considered standard of care for severe TBI. And sorry, for ICP, that's the abbreviation for intracranial pressure. And the second was that efficacy of monitoring and improving treatment outcome has not been rigorously assessed in previous papers. Previous papers were mainly non-randomized. and they had a lot of issues with confounding. And so Dr. Chesnut et al. Felt that a randomized controlled trial would be best. So they devised the benchmark evidence for South American trials, treatment of intracranial pressure trial. And the purpose of this trial was to answer two questions. The primary one was, will a management protocol based on ICP monitoring use result in reduced mortality and improved psychological functional recovery at 6 months? And the second question was, does incorporating ICP monitoring into management of severe TBI, would that provide benefits, including reduced complication risk and shorter ICU stays? So for the study, they basically created a multi-center cross-sectional study focusing on intensive care units in Bolivia and Ecuador. And the inclusion criteria for this study were patients greater than 13 years old with a history of TBI being treated in an ICU in those two countries. Patients that were included also needed to have a GCS score of 3 to 8 on admission or having dropped to that range within 48 hours of injury. And patients randomly were assigned to two groups, one being the intracranial pressure monitoring group and the other one being an imaging clinical examination group. And for the intracranial pressure monitoring group, an ICP monitor was placed as soon as possible to maintain an ICP of less than 20 with various treatments. And so for ICP monitoring, there are basically two ways that it's done. ICPs are normally between the 7 and 15 millimeters pressure in adults who are supine. And then when pressures go above 20, that's considered pathological. And the two ways they're measured are with an extraventricular drain, which is the picture on the bottom left, basically showing it entering into the ventricles, which are the pocket of fluids that make up the CSF, which kind of equilibrates the pressure in the brain. And it goes from those pockets all the way to an extraventricular drainage device or canister that collects fluid and also is able to measure the pressure in the brain. And then the other method shown on the bottom right is basically putting in a monitor directly into that pocket without draining any fluid off. And so in the study itself, for the demographics of the study, basically they had a total number of 324 participants. Median age was 29. Most of the participants were male. In terms of the Glasshouse, the GCS score, it ranged between 5, had a median of 5 in the ICP group and 4 in the ICE group. And they ranked different types of injury based on the Marshall classification on the initial CT presenting into the emergency department for the patients. And they also ranked midline shift for the patients as well. In terms of outcome assessments, they used trained examiners who were unaware of the group assignments. And this is where the randomized placement came into play. And they administered different tests at 3 and 6 months. Those tests included the Galveston Orientation and Amnesia Test, also known as GOAT, the Extended Glasgow Outcome Scale, and the Disability Rating Scale. And then using those tests, they created 21 components and gave basically points to those 21 components to measure the primary outcome of survival, duration of and level of impaired consciousness, as well as functional status and orientation, and neuropsychological status. And overall, each patient's outcome percentile was averaged from the 21 components and placed on a scale of 0 to 100, with lower percentiles representing a worse outcome. And then for the secondary outcome, that they used the length of stay of the patients in the ICU, which was measured as a total number of days and also represented by patients who have received at least one brain-specific treatment while in the ICU, as well as other systemic complications. And basically what they found was that there wasn't really any difference between the groups in terms of overall outcome. They found that there were around 56 patients that passed away in the ICP group versus 67 that passed away in the ICE group, which was not statistically significant, as well as having a cumulative mortality ratio of 39 versus 41. And this is a chart basically representing how many days after injury the patients survived in the different groups. Also showing the exact same thing, that there really isn't any statistical significant difference between the two. It looked at the overall survival versus 14-day period. And in terms of clinical outcomes, the hospital length of stay was shorter in the ICE group versus the ICP group. As I said, there were no statistical significant differences between groups, especially with respect to the ICU length of stay and mortality. There was no significant difference between groups in number of days on mechanical ventilation while in the ICU. One thing that was statistically significant was that with the ICP group, there was a significant higher rate of decubitus ulcers. And they believed that this was contributed to the longer length of hospital stay in the ICP group being in the ICU. The median time of ICP monitoring was 3.6 days for the entire group, and then 4 days with those that did need brain treatment while in the ICU. And the median and mean percentages of readings varied over 20 millimeters of pressure from 70 to 20% in the entire population, and then 5 to 13% in the brain treatment survivor groups. And in terms of adverse events, there were no serious catheter-related adverse events in either group. So the conclusions for the paper that they resulted with were, for patients with severe TBI, care was focused on maintaining monitored ICP at 20 millimeters of pressure or less, and it resulted that did not show any superior outcome or care compared to the ICE group.
Great summary. Yeah, I think you certainly hit all the high points. To put this in context, so this study was actually being done in the early years of this millennium. And why do we have to treat ICP above 20? Where did that all come from? Well, I actually chose to do my residency at what was then Medical College of Virginia, now Virginia Commonwealth University in Richmond, because I was told by my advisor at medical school in a different part of the country that he knew I was interested in neurotrauma and neurocritical care. He said, you got to go do your residency at MCV, because there were some real pioneers in the field there. And he said, it's the best place in the world for that kind of stuff. And way back in the late 70s, they put together something called the Traumatic Coma Data Bank, looking at this new thing called CT scanning and this new thing called the Glasgow Coma Scale and intracranial-pressure monitoring, to see if that would really make a difference in a way. Severe head injuries, they were called back then. Head injury patients were managed, because before, those patients just get thrown in a corner of the unit and ignored. And they found that an ICP above 20 correlates with the worst outcome. This is like a big revolutionary thing. So right away, everyone said, we got to monitor ICP, we got to treat above 20. And I think Che mentioned that it was a standard of care, but no one had ever really tested it prospectively. And a lot of guys in private practice started saying, I know what they do at the academic centers, but this guy he may have a GCS score of 6, but his CT scale looks fine. I'm not going to monitor his pressure. And a lot of those patients did really well. So that's what prompted some people to question this dogma that everyone with a low GCS needs an ICP monitor. problem is, how are you going to do that in this country when it's standard of care to monitor ICP in everyone? No institutional review board is going to approve a study where you're depriving half the patients of the standard of care, which I think is one of the reasons why Dr. Chesnut went down to Latin America, because he'd been collaborating with folks down there for a long time. And ICP monitoring was not the standard down there. So he was able to ethically do this trial there. One big problem, though, is that the pre-hospital care systems are very different in Western countries, in the United States versus down there. And I think there was a line in the paper that said only 45% of their patients arrive by ambulance. Most of the rest like private vehicles. So perhaps the most severely injured patients down in Latin America never even survived to make it to the hospital. But in this country, those are the ones who really benefit the most, perhaps, from aggressive ICP monitoring and aggressive ICU care. Another point to make is that, a lot of people read this article and said, oh, well, we don't have to monitor ICP. High ICP is not a problem. Well, that's not really true, because as Che explained, both groups of patients were getting high ICP treated. The difference is, in one group, you had a monitor and had to give you a number telling you ICP was high. The other group, you were just sort of deducing it based on their clinical exam and CT scan and things like that. Certainly this is not saying that the ICP is not important in TBI. It's more a question of, within the limits of the study design, it was hard to show a benefit. A couple other things, that this composite endpoint that Che mentioned, this sort of 21 different variables sort of put into one number, that's kind of an interesting approach. And it makes you wonder if perhaps one or two of those endpoints really showed us a significant difference, but that effect kind of got buried in the background of all the other confounding things that went into coming up with this one score. And when you submit a grant to National Institutes of Health or some other funding agency, people review it and they're pretty critical of it. I wonder what the discussion was in the room about use of a composite endpoint, because I think we'll talk about in one or two of these other papers, that's not common by any means. Generally, an outcome for severe TBI is based on some variant of the Glasgow outcome scale, which is different than the Glasgow coma scale that you mentioned. And by the way, it's pronounced Glasgow. Sir Graham Teasdale would not be happy with you if you pronounced it the American way, which is Glasgow. And a couple other things about length of stay in the ICU. It actually was a little bit longer in the non-ICP group, which kind of makes sense. They're not hospital length of stay, but ICU length of stay, because then they weren't quite sure when ICP was low enough to send them out of the unit. If you have a monitor in your head, pressure's low for a day or two, you send them out. If you're just kind of deducing that or inferring it indirectly, patients tend to stay longer. In others, let me ask you guys, why do you think there were more decubitus ulcers in the group with high ICP? Che mentioned 12% rate in the ICP group versus only 5% in the other group. What's the explanation for that? What would you guess? And all I can come up with, I've never talked to Dr. Chesnut about this, and Che, you're there, maybe you can ask him. I assume that the nurses were not really comfortable with ICP monitoring because it wasn't what they did. And if every time you turn and move a patient, the ICP goes up a little bit. You have to turn them to bathe them and things like that. Maybe they got scared, so they tended to leave those patients alone and not turn them as often as they needed to be. And that's why they had a higher rate of decubes, but I'm just speculating there. So obviously kind of a very controversial trial. I think that what a lot of people took away from this is, well, most people still think you need to monitor ICP in severe TBI patients, but maybe not everyone. Maybe if the CT scan really does look pretty benign and, the cisterns are wide open, there's not much sign of elevated intracranial pressure or edema, then maybe you could get by without monitoring those patients, assuming a clinical exam stays the same. At least that seems to be what I've seen around the country since this trial came out. But yeah, I should also say at the beginning of this, it's really hard to design a study and even harder to pull it off well, like this one was done. And there's no such thing as a perfect trial. And it's always easy to be a critic, right? It's always easy to criticize LeBron James when he doesn't play well, but it's hard to play as well as LeBron does. So keep in mind, even though we're going to talk about the weaknesses of all these trials, it's a huge amount of work, and all these are very important in terms of advancing our knowledge. So, Mike, do we take any questions or anything, or should we go on to the next one?
Yeah, absolutely. So there is a question in the chat that I'll put up on the screen here. So one, what is the utility? Oh, are you able to see that on the scrin?
Yeah, I can see that. Okay.
Okay.
So
great.
utility of ICP monitoring in patients with severe DAI without obvious mass effect, or brace edema with low G. So it's easy. Severe DAI is usually not associated with high ICP. And classically, someone doesn't have a very good exam, but you don't see a whole lot of swelling or edema or cisternal effacement or anything. So I'm fine not monitoring those patients, all those things being equal. But again, if you have any doubt, or if they have to go to the OR for a while for some orthopedic procedure or things that may take a while, then you tend to err on the side of putting a monitor in. So let's see, mean GCS different for two groups, 4 in one, 5 in the other. It's a pretty big difference. Yeah, in a big picture, it really is not that different. If you think about a severe TBI, traditionally has been defined as a GCS of 3 to 8. I mean, that might be the mean, but generally anybody below 8 is eligible for the study. Now, there are ways, I think we'll talk about it in the TX8 trial. There's lots of different ways to analyze your outcomes. And traditionally, believe it or not, even though we had a 5-point grading scale and a Glasgow outcome scale, we just lump it into good and bad outcomes. And there's a subsequent revision, the extended Glasgow outcome scale now is an 8-point scale, but people will still lump it into good or bad. So the analogy is that if you're a teacher giving grades in school and you can give somebody an A, B, C, D, or F, that lets you discriminate pretty well between who's really smart and who's average and who's not. But why would you just change that to pass-fail? It doesn't give you nearly the granularity of outcome. And we've learned that after decades of making the same mistake over and over. So one way to do the outcomes is look at the change on every component, every component of the GCS, those who came in with the GCS of 3, 4, 5, 6. So I think you're getting onto something with that question. So how do we determine who we should put an ICP monitor in based on CT, GCS, bad exam? The answer is yes. It starts with the exam. That's the most important thing. And generally, most people who are not obeying commands are probably going to get a monitor. It's the minority in whom maybe the CT scan looks fine, but their blood alcohol level is 4 times the legal limit. You may hold off putting a monitor on them if you think that's the real reason why they're not waking up, why they have a bad GCS. All right, should we move on to the next one in the interest of time?
Absolutely. So should we do the DEPRA or the CRASH 3 next?
Either one, your call.
All right. Jose, you want to take the CRASH 3 next?
Certainly, thank you there. Okay,
sure.
Let me share my screen here. Let's see. Let me know if you're able to see.
So it looks like it's coming up as you're sharing the screen to the presentation here, to the restream. So I think you just need to switch it to the PowerPoint.
Okay, I see. I see that. I apologize for that.
No worries.
Okay. How about this now?
Perfect.
Excellent. Okay, here we go. Okay. Good day, everyone. My name is Jose Chacon. I'm currently a medical student at the American University of Veterinary Science in Barbados. And today I will present you on the effects of tranexamic acid on death, disability, vascular occlusion events, and other morbidities in patients with acute traumatic brain injury, a randomized placebo-controlled trial. This one is presented from the Lancet and from a collaboration from what's known as the CASH 3 collaboration trial. So as Chair mentioned earlier about the TBIs here, basically every year worldwide, there's more than 60 million new cases of traumatic brain injuries worldwide there. Among those, the most common ones includes traffic crashes and falls. In terms of the incident, is increasing complication of TBI and increases risk of death and disability. Ongoing intracranial bleeding can lead to rise in intracranial pressure, thus could lead to brain herniation and even pose death. The idea behind tranexamic acid reduces bleeding by inhibiting the enzymic breakdown of fibrin blood clots, and thus commonly referred in the group called what's fibrolysis is the process. Basically, it's almost like the fibrinolytic process that we use a lot for clots, and in addition to in the brain, as well as also in the heart and so forth. But this medication is very strong, has been known to be used in other areas, in general surgery, gynecology, etc. There, and it works very quickly too. And this study was done. The purpose of this study was kind of like an updated approach to what it was from the CRASH 2 trial from the previous one, regarding about the administration of tranexamic acid within 3 hours of injury reduces death in patients with traumatic extracranial bleeding. Raised the possibility that tranexamic acid might reduce death from traumatic intracranial bleeding. So basically, the idea was to, as I mentioned, to see an up-to-date study to see if this idea is still correct and still valid. So what they did was, as I mentioned earlier, this is a very large collaboration involved in international multi-center randomized placebo-controlled trial of the effects of tranexamic acid on death and disability in patients with TBI was conducted. And adults with TBI who had within 3 hours of injury had a GCS score of 12 or lower, or any cranial bleeding on CT scan, and no major intracranial bleedings were eligible for this study. The time window for the eligibility was originally within 8 hours of injury, with primary endpoints was changed to head injury death in hospital within 28 days of injury, or patients treated within 3 hours of injury. In addition to their primary endpoint, which was the head injury, the secondary outcome involves also include early head injury related deaths, usually within 24 hours after injury, all cause and cause-specific mortality, disability, vascular occlusive, seizures, complications, other neurosurgery, days in intensive care units, and adverse effects within 28 days of randomization. Now, in addition, among those who were also excluded include those with a with GCS score of 3, as well as those with bilateral unresponsive pupils. In addition, this study also included that some patients were not able to obtain consent in order for this trial to be done. But under the declaration of Engl, if I pronounce that correctly, some of them were granted exemption and it could be added to the study there. So, and eventually, most of these were done based on good standard clinical practice or purposes. And then the result shows that 12,737 patients were randomly assigned from 175 hospitals in 29 different countries, in which 6,406, which includes 50.3%, were given tranexamic acid, and 6,331, which is 49.7%, were given a placebo. By the time outcomes data were recorded, there were 6,359 patients on the tranexamic acid group and 6,280 in the placebo group. In terms of risk of head injuries related deaths, was 18.5% in tranexamic acid group versus 19.8% in the placebo group. And relative risk was 0.94. And the relative risk of a head injury related death was 0.81 within 24 hours. When patients with a GCS score of 3 and those with bilateral unresponsive pupils at baseline were excluded, the relative risk was 0.72 within 24 hours. Pre-significant sensitivity analysis that includes patients with GCS scores of 3 or bilateral unreactive pupils baseline showed that 12.5% of the tranexamic acid group versus 14% in the placebo group. And when comparing secondary outcomes, it shows that given tranexamic acid within 3 hours, favorable outcomes when come those less than or more than 3 hours. Meta-analysis on the patients that had head injury related deaths were on either the tranexamic acid and placebo yield only 2 prior studies. Basically, it was the same the amount of studies that was collected based from the previous CRASH 2 trial. And then let me show you some real quickly. I'll show you some here. And basically, figure 1 is just showing you the entire schematic towards the end how it was given to from both those who were given the tranexamic and the placebo group. And basically, on this other graph here shows you the differences in the groups. It was mostly predominantly males. 8% were males, and as well as also other demographics, including they were checking also blood pressure differences and so forth. And in the next table here, you see was the effects of tranexamic acid and head injuries within 3 hours. It shows you that tranexamic acid groups had a lesser risk compared to the placebo group, and the same was true when the those with GCS scores of 3 and the unrestricted pupils were excluded. Shows this it was the same. And then in the next figure here shows you the risk analysis here. It shows that the tranexamic group had a much lower risk compared to the placebo groups when taking into account GCS as well as pupil reactivity, etc. And then if you see here on this figure right here, if you can see here, it just basically shows you the secondary outcomes. Basically, it shows that the beyond placebo group, as mentioned, placebo group showing on within 3 hours had a favorable outcome compared to those below under 3 hours and those over 3 hours there. Especially also they found out there was the only they found was not significant was the fact that it shows no differences when it comes to vascular occlusion and seizures effects. And then in this figure 5 here shows you basically a head injuries is compared to the previous both the CASH 3 and the CRASH 2 studies. And once again, it shows you the tranexamic group does shows improved favorable less risk of death compared to those on placebo, both and as you can see here. So the conclusion was that the CASH 3 trial provides evidence that tranexamic acid is safe in patients with TBI and that treatment within 3 hours of injury reduces head injury-related deaths. Early administration of tranexamic acid should be considered in patients with traumatic brain injury, as well as also, in addition, that because they only had 2 prior trials for the meta-analysis portion, they'd best recommend to have a larger randomized trial or need to determine mortality-associated head injury while on tranexamic acid. One thing I want to point out as well there, I should have mentioned this earlier, that some of the limitations with the study included that was noted in the study was that the study was unblinded, so they can that be considered issues with the study there? Could be there, but then again, given to the nature of it, it's the nature of it. And the second thing was that it was given the fact that there was basically a lot of issues and concerns. It concerns also with the fact that it was only done in very small populations there, so that's why that's why the last line here was best noted, because they want larger studies so it can be done with a much larger population there. Okay, this concludes my presentation. Thank you very much.
Great, thank you. Good job. So you may have noticed there's a lot of patients in this trial. And this is an example of what people call mega trials, where you just get huge numbers of patients and you try to go literally around the world to get as heterogeneous a patient population as you can, because that speaks to generalizability of a clinical trial's results. So in other words, I may have a very small specific group in my own little hospital and I prove that a treatment works, but is that going to work out in a wider population, out in the community, out in developing countries and things? So that's one of the advantages for doing this. You'll notice the data collection is actually pretty sparse. I mean, you could probably summarize it on one sheet of paper, as opposed to a lot of clinical trials where they're just like pages and pages and forms to fill out. There's this temptation to try to get as much data as you can. But, clinical trials are expensive enough to put on. And the more data you collect, the more expensive it gets. So there's a lot to be said for just the beauty and simplicity of these kinds of trials. Unfortunately, that's also the reason for some of the problems. Their outcome was death. And that's a really poor outcome measure for TBI. It's great for like trauma surgery or general surgery when your people tend to exsanguinate, as a common cause of death. But really with neurosurgery, you want to know not only if they survive, but if they survive with a reasonable functional outcome, which is what you try to capture in the Glasgow outcome scale and the extended Glasgow outcome scale. Another problem is the fact that they mix together severe and mild TBI patients. So just so everyone understands, we mentioned, Che mentioned earlier, the 15-point Glasgow coma scale. And very generally speaking, a severe TBI is somebody with a Glasgow coma score of 3 to 8. The moderates are 9 to 12, and the mild is 3 to 15. And there's a lot of discussion now that even those so-called mild aren't really mild because they can have significant cognitive impairments. But that's what we're talking about here. Well, if you look at the study, and I'm looking at my other screen here, in the methods section, the third sentence says that they were only going to include adults with a Glasgow Coma Scale score of 12 or lower. So in other words, just moderate and severe. And yet you saw the table Che put up, which is table 2 in the paper. Over a quarter of their patients were higher Glasgow Coma Scale score, mild. So I don't know if that was a typo or something, but you said you're going to exclude these folks, and yet they accounted for more than 25% of your patients. That's a problem. The other is the fact that a lot of them did come from developing countries, similar to the concern about the trial we just talked about. The Best Trip trial was out of Latin America. They have different pre-hospital care systems. Well, just a quick eyeballing, I think perhaps as many as a third of the patients came from Pakistan. If you look at the article itself, when you get past the conclusion, there's all this fine print at the end that then they list the sites and how many patients each contributed. So they also broke out in this article the fact that for the severes, there really wasn't an effect of TXA. But for the milds, they thought it did have an impact. But again, I think that may be weighted towards the fact that they had so many people from developing countries. So in this country, if somebody comes in with a mild traumatic brain injury, you may just park them in the emergency department and get a CT scan after arbitrary amount of time. 6 hours is a common one. In the meantime, you're keeping an eye on them. You get a scan, and if it shows things are getting worse, which is very rare in these people, then you can admit them or even operate. But otherwise, you can make sure things are going fine and you send them home. And they tend to get to the emergency department early. So it's a little hard to reconcile these results with common practice. I mean, very, very few mild TBI patients go on to die as an outcome. I think those were most of the comments. Oh, yeah, a couple other things. So this is based on a lot of literature trying to prevent intracranial bleeding. And I think that Jose mentioned, this is sort of a springboard off some trials of people with polytrauma, bleeding to death. You try to show improved outcome, and there may be a benefit there. But it's been really hard to design these trials in neurosurgery because almost all contusions enlarge to a certain extent. Now, a contusion may only be a few cubic millimeters in diameter, and then it gets to be a little bit bigger. So is that a failure of the drug you're trying to give to prevent it from enlarging or not? It's very problematic to design these things. Finally, the last thing for you guys to think about is if you're in the operating room doing a craniotomy on a trauma patient and it's just bleeding, there's basically 2 types of bleeding. One is from a specific artery or part of the brain you can see. You can try to coagulate that directly or try to put some Surgicel or gel foam or something on it. The other type of bleeding is sort of diffuse oozing from everywhere. And those are patients who may be coagulopathic. And that's when you sometimes ask anesthesia to give some fresh frozen plasma, give some platelets or cryo, or TXA sometimes, and even for some elective surgeries, some neurosurgeons will do that because it's antifibrinolytic. It's a clot stabilizer, in other words. But bottom line is that I don't think a lot of people modified their practice based on the results of this trial for some of the methodological weaknesses that I mentioned. So there's a question in the chat. Yeah, for patients for severe TBI, would you give TXA? No, not routinely. Perhaps, like as I just said, in the operating room, if there's this diffuse oozing and you really can't seem to get control of it and you've tried other things, we might give it. It does seem to be safe. I think that's one thing this trial showed us. The incidence of complications seems to be pretty rare for giving it, which is also consistent with practice in other areas that Jose mentioned, like gynecology and trauma surgery.
Great. Well, let me go ahead and share my screen. We can get started with the last one. Okay. Do you guys see the individual slide or the presenter mode?
Individual slide.
Okay, great. All right, so good evening. My name is Mike Rallo. I'm a MD PhD student at Robert Wood Johnson Medical School, and I'm going to be talking about the DECRA trial, or decompressive craniectomy in diffuse traumatic brain injury. So this was one of the first large multi-center randomized trials to look at whether or not decompressive craniectomy in severe traumatic brain injury was safe and effective. This is just the scope of the problem, which we've kind of hit on already, but this is data from 2021 showing that TBI-related death and disability remain important problems that need to be addressed by neurosurgeons. So for some background with this specifically, we were looking at, or the paper was looking at cerebral edema as a secondary consequence of traumatic brain injury. And the problem with the cerebral edema is that it can lead to the development of intracranial hypertension, which can result in cerebral hypoperfusion and ischemia, further exacerbating the injured brain. While there is medical therapy available for management of intracranial hypertension, the ICP can be refractory to these first-year treatment options. And that can be a challenging situation to deal with in a medical setting. And at the time of this study, to kind of work around that issue, there was an increased frequency of surgical decompression for severe traumatic brain injury and traumatic intracranial hypertension, but there wasn't much solid evidentiary data that supported its use. So for the design, this was, again, an international multi-center randomized single-blinded controlled trial. It took place over the course of about 8 years, from December 2002 to April 2010. And it was taking place in 15 ICUs in Australia, New Zealand, and Saudi Arabia. For the analysis, they used an intention to treat analysis, and it was powered to detect a 20% reduction in unfavorable outcomes, at least at the beginning of the trial, and then we'll talk a little bit about how that changed with their primary outcome. So diving into kind of our PICO assessment of this paper. So the patient population of focus here was patients aged 15 to 59 years who presented with severe non-penetrating traumatic brain injury, and severe was defined as either a pre-intubation or post-resuscitation GCS between 3 and 8, or a Marshall class 3 or 4 injury based on the CT scan. And again, this was non-penetrating because they were focused on diffuse TBI. There were some important exclusion criteria. So this one was probably the most subjective and kind of difficult to tell what it actually meant, but it was patients that were considered unsuitable for full active treatment. Patients were also excluded if they had dilated unreactive pupils, if there was a surgically relevant mass lesion, or if there was concomitant spinal cord injury or pre-hospital cardiac arrest. So for the intervention and comparison group here, so the controller comparison was the standard of care according to the Brain Trauma Foundation guidelines at the time, which included both tier 1 treatment shown here, and then after randomization, tier 2 would be attempted because these are the treatments for what would have been the refractory TBI. The intervention, of course, would have then been standard of care in addition to decompressive craniectomy. And the approach for this was a bifrontotemporal-parietal approach involving bilateral dural opening. And this was based on some previous literature by the Poland group. So the way this, my understanding at least, I wasn't able to find an image directly from that first paper, but it was an approach that involved burr holes placed off the midline, so lateral to the sagittal sinus, in the root of the zygoma, and then in the keyhole bilaterally. And then the bone was removed as a single cranial flap rather than taking bifrontal with 2 flaps, as is another bifrontal approach. So for the randomization, this was a stratified randomization by center and by the method of monitoring the ICP. So as Shay mentioned, there are 2 main approaches for monitoring ICP, either through an EVD directly or through a parenchymal catheter. So they essentially stratified to make sure that they were incorporating a approximately equal number of each monitoring method. So patients would have been chosen for randomization if they had a spontaneous ICP greater than 20 millimeters of mercury, lasting for a sum of 15 minutes within a single hour. And this would have had to occur within 3 days following the injury. For the outcome, so I mentioned this got a little wonky. So the first primary outcome was prior to an interim analysis that was conducted in January of 2007. As we talked about earlier, this was kind of a problematic outcome in that it was a composite score of death, vegetative state, and severe disability. So again, kind of a yes, no, or 0-1 kind of outcome. And this would have been a score consistent with 1 to 4 on the extended Glasgow outcome scale, which is shown here on the right. After that interim analysis, they switched to looking at the functional outcome at 6 months based on a proportional odds analysis of this outcome score. So essentially, they were taking in these patients then the median Glasgow outcome extended score. For secondary measures, they looked at things like the hourly ICP, the intracranial hypertension index, which was the number of end-hour ICP measurements greater than 20 divided by the total number of measurements. They also looked at proportion of survivors with the scores between 2 to 4. They looked at things like the number of days in the ICU and hospital, as well as in-hospital mortality and 6-month mortality. So this is the flow chart for the patients. So there were over approximately 3,500 patients that were assessed for eligibility, meaning that they presented with a severe traumatic brain injury according to the 2 criteria we set. But then 3,300 were excluded, and we see that the biggest reason for exclusion was that there were present mass lesions, or that the ICP wasn't refractory. It was indeed controlled by those tier 1 treatments. We then, with the randomization, had 150 patients who were randomized to the craniectomy or the standard care group, and that was 73 and 82 respectively. There's an important note that wasn't included in this figure, but is important to mention, is that there was quite a bit of crossover here. So 4 patients within the standard care group received craniectomy within that 72-hour time frame. The protocol allowed for a survival or a indication to do the surgery if it was considered life-saving within that 72 hours. And then after the 72 hours, the patients could have had the craniectomy performed if it was deemed necessary by the treating physicians. And this occurred in 15 patients. And this in total summed to 23% in the standard care that ended up undergoing the surgical procedure in the interventional group. Finally, for the analysis, one of the strengths of the study is that they had no loss of follow-up or withdrawal of consent, so they were able to analyze everybody that was randomized. So these are just the baseline characteristics, and I'll just draw your attention to the bottom left here, which is the reactivity of pupils. So this was the only variable at baseline that was different between the two groups. And this has been a source of criticism with this paper in that it indicated that the patients likely weren't well stratified based on important injury indicators. For the primary outcome, so this is the extended Glasgow outcome scale score, kind of splitting it between less than 4 and greater than 4. What they saw is that there were 70% with a score less than 4, corresponding to an unfavorable outcome, versus in the standard care group where it was only 51%, and that was a significant difference there, with an odds ratio of 2.21, indicating that the decompressive craniectomy might have been associated with an unfavorable outcome. I mentioned then there was kind of a secondary primary endpoint, which was the actual median score within the groups. And this also showed that there was a higher median score, a lower median score, indicating worse outcome in the decompressive craniectomy group. They also did some adjustment here for both pre-specified variables, including age, the GCS prior to intubation, the GCS motor following resuscitation, and then the Marshall class. In addition, they did a post hoc adjusted analysis, trying to control for that difference in baseline pupil reactivity that I mentioned. And it's interesting, the adjusted analysis in some way mitigated the trend towards unfavorability in the decompressive craniectomy group, but really it was only seen on both with the post hoc analysis. So again, that's another kind of criticism of the trial, and that, or of the conclusion that there was no difference, and that it had to be the post hoc analysis to see that. For secondary outcomes, so I don't think this is really surprising, but this is a graphic showing the difference in mean intracranial pressure between the decompressive craniectomy and standard care group. So after randomization, there was a lower mean ICP in the decompressive craniectomy group, and this was significant here. Other secondary outcomes that were looked at that were different in the two groups. So craniectomy here was associated with other indicators of ICP, including the intracranial hypertension index and the cerebral hypoperfusion index. In addition, patients randomized to craniectomy had a shorter length of mechanical ventilation, as well as a shorter ICU stay, although there was not a significant difference in the total hospitalization stay. In total, patients with craniectomy experienced complications at a rate of 37% compared to standard care, which was 17%. Importantly, hydrocephalus was much more common in the craniectomy group, so about 10% of patients in that group had hydrocephalus as a result. So in total, some of the conclusions here, and I do think that overall the group tried not to really overstate the conclusions. So they showed that while early bifrontotemporal decompressive craniectomy effectively reduced ICP, it did not improve functional outcomes, and potentially it worsened those functional outcomes. For some of the other secondary outcomes, like I mentioned, there was decreased length of mechanical ventilation, ICU stay, but not overall hospital stay in the craniectomy group. And there was a higher rate of complication in the craniectomy group, like I mentioned, including hydrocephalus. But they did conclude that these were lower than some previous reports. So they interpret that as a evidence for the safety of this procedure, but likely not a benefit and likely a harm associated with the procedure. So just an appraisal of the study. So some of its strengths for the patient population that we were looking at, it was a decent sample size, so it could be considered a large study. It was randomized and it was multi-center. Outcomes were assessed by blinded observers. There was no loss of follow-up or withdrawal of the consent, and there was a standardized protocol for both the medical management and the standardized procedure for actually performing the craniectomy. There were a number of weaknesses that need to be acknowledged. And the first one is just recognizing that doing an emergency surgical trial is incredibly challenging due to the need for 24/7 screening and enrollment. And the fact that the treatment team cannot be blinded by the nature of them being the ones that perform the surgery. 19 patients, as I mentioned, or 23% underwent crossover from the standard of care to craniectomy, and that's a significant and substantial portion of the standard of care group. One of the biggest criticisms has been that this threshold of 20 millimeters of mercury for 15 minutes within an hour is a pretty low threshold for performing craniectomy. And in practice, there likely aren't many neurosurgeons that would have performed the craniectomy in that case. And then finally, as I mentioned, the primary outcome was changed after interim analysis. And this is kind of a great summary by Dr. Valadka in one of his editorials on this paper, was that DECRA was the right trial at the right time, given the context that we were in with the increased frequency of the surgical procedure, but not much evidence for it. All right, and then I did just want to acknowledge that there has been a later study of decompressive craniectomy for traumatic intracranial hypertension that, while it didn't show unfavorable outcomes, it was my interpretation of it was that it was essentially saving a lot of patients who otherwise would have died, but leaving them in a vegetative state. There was kind of a lot of movement between those groups. So I'm going to stop there. And
okay.
Yeah,
well, Mike, just
yeah,
very thorough. Just to maybe restate some of the things you did and give a little history. So decompressive craniectomy has been around for at least 120 years and probably a lot longer if you look at some of the skulls from antiquity that have undergone trepanation. In 1974, I believe it was, before CT scanning was on the scene, Paul Cooper at NYU published a series showing dramatic reduction in mortality in acute subdural hematoma patients if you do a craniectomy. But then a couple years after that, he published what was essentially a retraction, saying, well, they really don't do that well, So that threw cold water on this for a few decades, but gradually neurosurgeons, of course, have to do something. We don't do well just sitting around the bedside holding our hands, wondering what we can do. So they started taking off more and more bone flaps, and it kind of became a thing. And even patients, so you got to ask yourself, why are you doing a decompressive craniectomy? Is it because a patient just walked in the door and you think you're going to prevent bad things from happening? Or is it someone in the ICU where you've gone through the standard treatment protocol of sedation, osmolar therapy, CSF drainage, paralysis, maybe even hypothermia or something, and it doesn't work, and you're sort of last ditch. In this case, there's a lot of, as Mike mentioned, there are a lot of people out in the community, in the field, who are taking on bone flaps prophylactically, thinking you prevent something. Well, we've never, ever been able to prevent elevated intracranial pressure and improve outcomes, even though we've tried everything from hypothermia to decompressive crani to paralysis to giving barbed right off the bat and giving early mannitol, and on and on and on. So this, as I mentioned in those comments that Mike showed, this was the right trial at the right time, because this was essentially a trial of just taking off a bone flap on someone who would never go to the OR normally. And again, as you heard, their treatment threshold was 15 minutes. a total of 15 minutes and 1 hour of ICP being high. So it could be 3 minutes here, 2 minutes here, 4 minutes there. If it hit 50 minutes, you went to the OR. And the mean ICP at time of randomization was only 22 millimeters of mercury. Now, I am not going to take someone to the OR and rip off their forehead if the ICP is only 22 millimeters of mercury. You know, you would try a little harder to control it. You may even raise the treatment threshold up to 25, you know, but decompressive craniectomy is a big operation, especially the big bifrontotemporal-parietal approach they recommended. You know, to do it right, you have to go all the way out through the frontal sinuses, which creates a whole host of other complications. It makes the operation a little more complicated. Most people, I think, if you're going to do this, would tend to do a unilateral one side or the other. It's a little quicker and easier, perhaps less morbid for the patients. Another point, as Mike mentioned, this took them 8 years to do this. They screened almost 3,500 patients, and they enrolled fewer than 5% of them. So partly because this is a rare disease, or partly because it's hard to find people who fit into these trials, you have to wonder if the fact that trial took so long, you know, spread over 15 centers in Australia, New Zealand, and Saudi, that maybe that has something to do with it. Let's see, I'm looking at my other notes here. Oh yeah, the whole pupillary thing. So when this was presented at the neurosurgery meeting years ago, it was presented by Sir Jeff Rosenfeld, the second author on the paper. He's a neurosurgeon. And parenthetically, a few years ago, I was president of the American Association of Neurological Surgeons, and I had to pick someone to win the International Distinguished Service Award. And I picked Sir Jeffrey for all the great work he's done in terms of research and in developing parts of the world down in the Southern Hemisphere. He presented it, and the person who commented just it was very dramatic, ripped into him. It was way over the top for some of the weaknesses that Michael mentioned. How, you know, normally in a randomized trial, if you randomize well, you're supposed to sort of even out some of the potentially important factors like lack of pupillary reactivity. Now, an exclusion was pupil was blown and not reactive. But if it was just the small and not reactive, it was okay. And that's what happened here. Yet for some reason, there were, you know, 2.5 times or more than 2 times as many patients in one group than in the other. So that caused a big ruckus. So initially, as you heard, the sort of the raw results of the trial were that decompressive craniectomy made patients worse, you know, diffusely injured patients, which was hard to believe. Even if you sort of broke the rules a little bit, did this post hoc analysis to account for the pupillary reactivity, it certainly didn't make them any better. So at least we know that this is not a reasonable operation to do. Also, although they did a big bifrontotemporal craniectomy and opened the dura, what a lot of people suggested, they should have gone deep to the skull base and released the falx, so cut the base of the falx where it attaches to the skull base to help untether things a little bit, and they did not do that. Finally, as you heard, ICP was controlled a lot better, but we know that. That's why a lot of people were doing these operations willy-nilly back then. They figured ICP is lower, so that has to be a good thing. But this study showed, well, ICP may be lower, but it doesn't lead to improved outcomes, which is the most important thing. And found the complication rates very high. I mean, decompressive craniectomy is a horrible thing to do to patients. You only do it if you really have to. Then Mike went on to mention the trial from Peter Hutchinson and his group at Cambridge, which was a little bit different than this. So this trial that we just talked about, the Decker trial, was for diffuse injury where you do a decompressive craniectomy right off the bat. Hutch's trial was kind of end of the line when you've gone all the way through your management algorithm and there's nothing left, then you would randomize patients. And this is kind of getting into the weeds, or as they say in America, inside baseball. But remember I said there were, you can take the Glasgow outcome scale and break it up into an 8-point scale. And generally, the top 4 categories are good outcomes. The bottom 4 are bad outcomes. What they did in Hutch's trial in Cambridge, they took the top 5 categories and said they were good outcomes. So something called upper severe disability. They said that's going to be good, not bad. And they pre-specified that up front, so it's legal in the terms of the rules of trials. And that's how they found the benefit to doing decompressive craniectomy. A lot of people would not agree with that. They said, you know, with all due respect, I think upper severe disability is not a good outcome. So again, more controversy. And finally, I know we're over time, but just to tell you all briefly, just less than 2 weeks ago, another important paper was published by Peter Hutchinson in the Cambridge group in the New England Journal. This one is called Rescue ASDH, or the trial that Mike showed you was Rescue ICP. This is Rescue Acute Subdural Hematoma. And the question is, you did a trauma craniotomy for an acute subdural. You've taken out the clot. You're looking at the brain. Do you put the bone flap on or not? A lot of people just leave the bone flap off. They figure the brain's going to swell. Patient's better off if we don't. So patients are randomized to either putting the bone flap on or not. And long story short, no difference between the groups. What was interesting, though, and this is somewhat what you might expect, in the group in which you put the bone flap on, they were much more likely to have to go back for further surgery, generally taking off the flap because ICP was too high, so maybe you should have left it off. But in the group in which you left it off, they were statistically significantly more likely to have wound problems. From the craniectomy, the wound breaks down, you have to go back in and put the flap on, and you tend to get infections and things like that. So overall, no difference in outcome. You can kind of choose the complication you'd rather have. Either have to go back to the OR again and take off the bone flap, or have to deal with wound breakdown. But again, as I said earlier, it's very, very hard to do these trials, and the group at Cambridge is really outstanding, as is the DECRA group, Jamie Cooper and Jeff Rosenfeld's group in Melbourne. Questions? What about the unilateral frontotemporal parietal decompressive cranial? As I said, I think that's what most people would tend to do. Now, perhaps rarely, if the damage is primarily frontal, I might go for a bifrontal, but generally we try to do one side or the other, at least in this country. It tends to be quicker and easier. The other comment, this is a good study to show that reduced ICP short-term doesn't translate to better long-term outcome. Is that a fair statement? Absolutely. We have lots of ways to lower ICP, but whether it's mannitol, hypertonic saline, drain CSF, hyperventilate, hypothermia, barb coma, decompressive cranial paralysis, none of them has been shown to improve outcome yet. So that is not only a fair statement, that's the curse that plagues every neurotrauma expert, trying to find a way to actually improve outcomes from this disease. All right, Mike, I'll turn it back over to you.
Thank you so much, Dr. Valadka. That was really informative, and I appreciate you being able to put the papers into context, given your lauded career in neurotrauma. So thank you for that. And I think we addressed all the questions. So go ahead and wrap it up, and we'll see folks back next week for the session on the robots and neurotrauma. So are they coming? We'll find out from Dr. Samadani. All right. Take care, folks.